Okay, welcome to Labor and Health. We're going to try to get through these quickly today. We will be gaveling in at 9 o'clock upstairs. So let's go ahead and take a roll.
Senator Barlow,
Present.
Senator Bouchard,
Excused?
Senator Dockstader, Senator Hutchings, Chairman Baldwin.
Here.
We have 4 present, Mr. Chairman, and 1 excused.
We have a quorum. Committee, audience, I don't need to remind anybody here about decorum. The guy who owes us donuts is not here today. If your cell phones are on and they ring, you owe me donuts for, not me personally. Senator Dockstader would like maple bars at the next committee meeting. I like chocolate glazed. So if you have your phones on, please turn them off. Be kind, be courteous, and we can get through this and everybody will be happy. And if it's good enough, we'll sing Kumbaya at the end. 2 bills before us. First one we're going to hear is House Bill 14. These are committee bills. And we've looked at them, and there's been a lot of work done on them since we last saw them, particularly in this first one. And you know what I think I'll do? Let's bring some other people up here. Department of Health, are you going to speak on this one? Come on up. Let's just get all 4 seats full really quick. Let's bring 3 other interested parties. And we're just going to briefly look at this. How about the Hospital Association come up so they can talk? Board of Medicine, come on up. Come on down. Go ahead and let's just walk through the bill real quick, if you would. Go ahead, sir.
Yep, Mr. Chairman, members of the committee, Lee Grossman, State Medicaid Agent with the Wyoming Department of Health. Mr. Chairman, all due respect, I mostly want to stand for questions. I don't know that I'd be the best person to walk you through this particular piece of legislation. If I may respectfully decline that invitation. But that being said, Mr. Chairman, we obviously talked a lot about this during the interim, especially at our meeting in Casper. I wanted to make sure that this committee is aware that there is no impact on the Medicaid program, just by virtue of this being in Title 26. Medicaid is a public health benefit plan. So accordingly, that's why you'll see no fiscal note from us, et cetera. But that being said, Mr. Chairman, wanted to see, provide that clarification, dodge the invitation, and then stand for any questions.
Very, very good. We appreciate it. Just a brief overview of where this bill comes from. This bill came to us as an interim topic about the difficulties that medicine generally has with prior authorization rules that are in place now. And you've all heard me say it ad nauseum. The hoops that we've had to jump through and the things we had to go through is not good for medicine. It's not good for the patients. It's not good for anybody. So we're trying to fix it and correct it and make it a smoother system. And I haven't had time to really look at the product totally, but you can go ahead and sit down if you want, but thank you for coming up, but don't run too far. So the bill looks to correct a number of issues with the prior authorization process. And I think it does so successfully, fairly well. It's not a silver bullet. It doesn't fix everything. We don't do that here very often. There are no silver bullets in medicine. But if you want to go ahead, hospitals, go ahead and go ahead.
Mr. Chairman, actually, I've got a very small piece of this, so I think that Hospital
Okay.
Association Medical, and then I can just add on at the end if you don't mind.
Look at it, now everybody's jumping up. Wow. Okay, write that down that you said that somewhere. Let's just go down and introduce everybody that's up here real quickly first. If we can go ahead and start down here with Heather.
Good morning, Mr. Chairman, members of the committee. My name is Heather Roday, and I represent Blue Cross Blue Shield of Wyoming.
Good morning, Sheila Bush, State Medical Society.
Very good.
Morning, Mr. Chairman, committee members, Eric Bully with Wyoming Hospital Association.
Mr. Chairman, I'm Josh Hannes, also with the Wyoming Hospital Association.
Good morning, Chairman Baldwin and members of the committee. Denise Burke, representing CVS Caremark and Aetna.
Mr. Chairman,
Gotta
members
talk,
of the committee, Mike.
gotta talk into the mic.
Oh, sorry, no microphone. Mr. Chairman, members of the committee, Mike Mosier, Cigna, and also speaking on behalf of the Pharmaceutical Care Management Association.
Very good. I would remind everybody to speak pretty close to the mic because there'll be several people listening online as well, and that's the only way they can hear you, as well as some people in the back of the room. So with that in mind, whoever from the group would like to start us off.
Mr. Chairman, if it's okay, we'll try and do what we did in the House, and I'll introduce the topic and then defer to Ms. Bush, one of our partners here, to walk through some of the changes in the bill.
Okay.
And if we're going to start the way that we did last week, happy Valentine's to the committee.
That's a bad start because you're late, but go ahead.
So realistically, we believe this is probably one of the most significant healthcare bills this session and in many sessions before. It's a culmination of good, hard work with hundreds of committed and combined hours of meetings, back and forth, and compromise. And there's been some bruises and some bleeding, but we have worked hard together to come up with what you have before you today. Prior authorization is a huge issue. It became more apparent to me during the past 6 months as my family has dealt with the frustrations, and they are real and they're difficult. When you're sick or hurt and need to get help, we need to remove those barriers. I'm lucky because I spent the last 3 decades in healthcare, and even I suffer setbacks and frustrations. And we think about the customers that aren't in the industry. They don't know those things. And this legislation, this bill helps to address that and helps our consumers. The bill is a great start to a really complex issue and a growing problem. We're grateful for the hard work and the collaboration that we've had with this committee, in particular Senator Dockstader, Representative Penn. They've gone above and beyond. We're grateful for the hard work that we've put in with the medical societies, our partner, and with their insurers. And we spent a lot of time together after the final meeting in Saratoga. And we really think that we've come up with what we think is a good compromise, a good start to this growing problem. And we would ask you to move the bill forward. And with that, I'd answer any questions and turn the time over to Ms. Bush.
Any questions for Mr. Boley before we move on? Go ahead, Senator Barlow.
Thank you, Mr. Chairman. So I think it would be helpful as whoever's going to kind of explain the bill, or as you get to explain the bill, what the changes were from the interim to the House to what we have now as a product, just so we can key on them more quickly. Stuff that's all still in agreement from then, fine, leave it alone. But where the changes were made. Thank you, Mr. Chairman.
Any further questions before we move on? Seeing none, let's go ahead, Ms. Bush.
Mr. Chairman, members of the committee, Sheila Bush, again, with the State Medical Society. I'm happy to walk through those changes. So I will just start sort of at the beginning of the bill. I recognize you have an engrossed copy that you're referencing. So forgive me if some of my page numbers are wrong. I realized just now sitting here that my page numbers refer to the previous copy, but I think conceptually we can certainly walk through those. So the first change you'll see, we've added a step therapy definition. That'll be important for a later change that we've made in the bill. Pages 7 through 9, we've just changed, I think, professional to healthcare provider. That was something that was asked, and it simply broadens the definition to capture everyone more accurately.
Go ahead.
Thank you, Mr. Chair. When you're going through the bill, if you would, when you say page 7, there's 23 lines on page 7. Could you give us the line number when you're saying you've made changes so I can kind of get an idea where you are about changing provider? Yeah, I think that'll be better if you have that. Thanks, Eric. Thank you, Mr. Chairman. Thank you, Sheila.
Mr. Chairman, Senator Hutchings, I'll do my best. This requires me memorizing where the amendments were, so
Gotcha.
this will be a really
It'll
fun
help me
test today.
track. Okay.
You've
Yeah.
got lots of help at the table.
Yeah, thanks. I do have a lot of help here.
Yeah.
So,
Never seen this before. That's great.
so the next, I think, meaningful change that was
Excuse
made. Mm-hmm.
me, can you go back to that first one change that you
Yes,
mentioned? 'Cause
absolutely.
I totally lost.
Okay, reset.
Yes.
Thank
So
you.
do you want me to go back to the step therapy definition?
You said page 7 through 9.
So it's just in multiple areas. The original copy, everywhere it said healthcare professional,
Okay.
strike
healthcare-
professional.
Okay, just a second.
First of all, before we go any further, remember, all the communication needs to go through the chair.
Thank you, Mr. Chair. Is it healthcare provider?
It's now healthcare provider.
Okay, so it was professional. Gotcha,
Yes.
gotcha.
So,
Thank you, Mr. Chair.
so Mr. Chairman, I think what I'm walking through are the amendments that we came to in a compromise package that was on the original introduced version of the bill. So we won't need to track these in. All of the changes I'm describing to you are embedded in the engrossed copy. Does that help?
Mr. Chair?
And you have a copy of the original bill there, Senator.
Oh, gosh, yeah. I don't want to be flipping back and forth, so I just want to make sure, Mr. Chair, that I'm tracking and we can go fast.
Okay.
But it's really simple. If she says provider was professional, I'll just write that in.
Yeah, okay.
Perfect.
We've got another quick question here. Senator Bouchard.
Yeah, thank you, Mr. Chairman. I mean, we're looking at the engrossed. We don't have to go over what you did in the House if you don't want to, I don't think. I
Yeah.
mean, we can see it right here.
She's talking, it's up to
Yeah.
her.
So just hit the high points and what the
Mr.
changes were the
Chairman.
best you can. Go ahead.
I'll do my best. It was my understanding I was asked actually to go through the changes that we made in the House so that those could be
Yeah.
presented in the Senate. So I'm trying to comply with what was asked of me. We are, to be clear, we're not asking for any changes this morning. We're simply walking through what happened in the House. So the engrossed copy for this group sitting before you is where we are and what we're happy with. And so I'm not presenting any changes for you to make today.
Right.
I'm simply explaining the difference between the introduced version, the changes that the House made, and that we're in support of those and unified in the bill in its engrossed version.
Okay, proceed.
Thank you, Mr. Chairman. So the meaningful change, I think, was the shift from consultation prior to denial to post-denial. So you'll find that on page 10, I believe, of the engrossed copy. Or it's on now page 11. So at the top, it says consultation after issuing an adverse determination. 11, Senator Hutchins.
Gotcha.
So you'll remember through the interim, this language originally was a consultation prior to denial. And through some good work of this group, we compromised because there were some real problems with being able to facilitate what we had originally put in the bill through the summer. And so this language before you in the engrossed copy is the agreement, the compromise position. This now is a consultation after issuing an adverse determination. I think the simplest way of describing that to you is a codification of the peer-to-peer consultation process. We have insurers who do that periodically, not all of them do, and this would create consistency and create a space that is predictable for both the provider and the insurance company to work through debate over medical necessity. It gives a timeline for that to happen. Would you like me to move forward?
All right, go ahead.
The next is your timelines. So if you go to page, in the engrossed copy, 14, you'll remember that the original version of this bill was a 24-hour timeline turnaround for urgent conditions or urgent requests. We've compromised to 72 hours for that. And then if you follow through to the next section where they do non-urgent, that has moved from 5 business days to 5 calendar days.
Was 24.
Go ahead, Senator Bouchard.
Mr. Chairman, so my question is, if it's an emergency, is there an override in here somewhere?
Mr. Chairman?
Go ahead.
Senator Bouchard, emergency conditions don't, they're not part of the prior authorization process. So emergency conditions are, the care is delivered, the patients are taken care of. They're not subject to the prior authorization process at all.
And you talked about the non-emergent. Where was that?
Non-emergent is on page, is that the engrossed? Yeah. I think non-urgent is on page 14 or bottom of 13.
Okay,
So non-urgent is bottom of 13 and then moves into page 14.
okay. Okay, proceed.
Okay. The next section is the prior authorization determination, or the duration for prior authorization. Those start on page 15, the length of authorization, and move through page 17. This section was changed starting on page 15 at the bottom of 15, the length of authorization. It's just, there was some clarifying language added, so the original bill just said it shall be in effect not less than a year. This brings some clarity and divides out outpatient from inpatient, and separately pharmaceutical.
Yeah, see, separated out, Schedule 2 narcotic, okay.
Comfortable? Okay.
Proceed.
The next section is on page 18, moving into page 19. And it is a prohibition on forcing a patient to repeat prior failed step therapy protocols. So this was an area where the insurance companies came our direction and offered to help us with something that is very concerning for patients. We are not doing a robust step therapy reform, but this was an area that we thought could cleanly be included in this bill, and we really deeply appreciate insurance helping us with this piece. We talked about what step therapy is in the interim, but I'd be happy to briefly review it again.
If you would.
Sure. So step therapy is, and again, that definition is at the beginning for what step therapy is. But for the purposes of this section, I think the simplest way to describe it is if a patient is diagnosed with a condition and a pharmaceutical remedy or treatment is prescribed, often there will be different options for the prescription that can address a certain condition. And so it is the practice of a step therapy protocol to sort of first try frontline drugs, if I can use a lay term that way, that would probably be more affordable. There's new drugs on the market that we're all aware of. They're far more expensive. And so it is, in terms of being stewards of finite dollars, it is the practice to first have patients try that frontline therapy. If they fail that frontline therapy, then they advance to the more expensive, often it's a biologic or a different medication. And so once they achieve that more expensive sort of tier of medication, this language prohibits an insurance company from at any time making a patient fall back and repeat those frontline therapies.
And again, I need to read through it closer, but I'm assuming that prohibits, if a company changes insurance companies, say the mine, I know let's say that, the given mine changes insurance companies from X to Y. Y says, oh, I'm sorry, that's not on our formulary. Does Y have the ability to then go back and say, oh, you got to go back to our step therapy and make them go back to that?
Yeah, yes.
Okay, very good.
That
Proceed.
is our understanding, Mr. Chairman. Any other questions? Then the next section is the gold carding exemption amendments. And so the gold carding, as you might remember, is an exemption for having to engage in the prior authorization process.
Yep, yeah, you got to identify where that's at for. Senator Bouchard, go ahead.
Thank you, Mr. Chairman. I'd like to go back to page 18, where it says, you're not required to repeat a step therapy protocol. I mean, from what I'm looking at in this language, it looks to me like, so you have a patient that was prescribed under this therapy, and they discontinued use because it didn't work, it had an adverse reaction. But on the other side, you get the insurance company that says, well, this is the drugs that we allow for this particular problem. So this looks like kind of like a step in between, or not a step, but a wall in between that to say, well, if the insurance company pays for this drug, but this patient says, no, it didn't work right, or I was sick, that's what this safeguard is here for?
Ms. Bush?
Mr. Chairman, Senator Bouchard, sort of, but not entirely. So it doesn't interfere with an individual drug or insurance company's drug formulary. And I don't know if that's maybe what you're referring to. So it doesn't force an insurance company to pay for a medication that isn't already on their drug formulary, and that isn't the intent. Really, it's step therapy is its own kind of section or aspect of insurance. And the example that was given to me, and I always hesitate to do this because I'm not a medical professional, but I trust that.
I'll clarify. with
Yeah,
you.
thank
Go
you.
ahead.
So a good example is atopic dermatitis. It's a fairly common skin condition. It happens in pediatrics a lot of times, or also in adults. So traditionally or historically, the frontline therapies for that has been steroids. They're pretty affordable. the percentage of the population that responds positively therapeutically to those frontline therapies is very small. So now you have some new medications on the market. They're far more expensive, but they're very effective. And so there still is a small percentage of the population, I don't know what that percentage is, who will respond to that frontline therapy. And so in terms of being, fiscal stewards and protecting finite dollars and those kinds of things, it is the practice to have those patients first try those frontline therapies. Some will respond positively, and then they do fine. For those who don't respond positively, at that point, it elevates them to that other tier of medication, which are more expensive. This language here just says, at any point in a patient's journey with that condition, if they were, it's documented and their provider works with the insurance company and does all of the necessary things, that patient doesn't have to go back to those therapies that they tried originally, that they didn't have a positive therapeutic outcome, or like you said, they had an adverse, they had some sort of adverse event. They don't have to do that again. And so there are some companies, I would say none of these good friends with me here today, but there are some companies who do like to, even if they've achieved that higher status and a more expensive medication, they'll play, I won't say that, they'll just force a patient to go back and try those medications. And from the physician perspective, that does harm. And it's against their oath to do that harm. And so it's really hard to put them in a position to prescribe a medication for a patient that they know didn't do well, they had an adverse outcome. And so that is the intent of the language. Did I help at all?
Very well explained, actually.
Thanks.
Okay, go ahead, Senator.
Thank you. That opened up another question on page 18.
Okay.
Lines 20 through 23. Just looking at it, it seems a little prescriptive. The enrollee's prescribing provider shall submit justification and clinical information if requested that demonstrates a clinically valid reason for why a covered prescribed drug is needed and documentation of completion of previous steps. It seems like you're saying, hey, this drug didn't work, so I gotta go out and get all this clinical stuff saying why. Is that what I'm seeing?
Go ahead.
Mr. Chairman.
Thank you.
Senator Hutchings, yes, but that's also the entire relationship between providers and insurance is a checks and balances on both ends, all in the name of patient safety and patient care, and both entities in this equation of healthcare doing their due diligence. And so without that documentation, it would be really difficult for insurance companies to just sort of on blind faith operate on the honor code.
And I would add to that, any age of EMRs, which most everybody's using, I'd rather not, but that's very simple. Even though it takes up several paragraphs here, it's actually a very simple process.
Okay.
It's very straightforward, and you can look back and it's very straightforward. Okay, go ahead and proceed. Did that answer your question?
Yeah.
Okay.
That's fine. Thank you for the verification too, sir.
So moving on to the gold carding section, I believe it starts on page 20. It's titled Provider Exemptions from Prior Authorization Requirements. Gold carding is sort of the tagline that's been attached to this, but it is, again, just to sort of jog everyone's memory, it's this process by which a provider submits a certain number of procedures. In our bill, it's 5. And if 90% of those 5 procedures are approved with that individual company for the same procedure, they're granted an exemption from participating in the prior authorization process specific to that procedure with that company for 12 months. And so some of the changes that were made, I think the original version of the bill, it was 80% of 5 procedures. The states that have passed this and the conversation nationally really is 90%. And it's 90% of 10 procedures. And so I think in an effort for insurance to really acknowledge in a good faith way that we have some patient volume challenges here in the state, asking a provider to do 10 procedures per company is probably a bar that's a little too high. We would not have providers easily attaining that exemption. And so in acknowledgement of our low patient volume, it's 5. And recognizing that the national standard is 90%, 80% is where we originally started. In an effort to acknowledge the national sort of precedent for this so far, and I hesitate to use national, it is 5 states who've adopted this. But 90% of 5, if everybody is doing the math with me on this early morning, is 4.5. And we can't authorize half of a procedure. And so we'll round down to the nearest whole number. So of 5 procedures, if a provider gets 4 of those 5 authorized, they will achieve that exempt status.
Go ahead, Senator Hutchins.
Thank you, Mr. Chair.
Mike, please.
Thank you, Mr. Chair. Mike's this year. In layman's terms, if I can do that, is this kind of like when you fill out a form online, if you click this box, you don't have to put this information in anymore? You're kind of saying, once you do so many, you don't have to get prior authorization anymore. Is that what's going on in this gold carding?
Mr.
In a
Chairman.
way?
Maybe-ish, I would say, possibly. I think what it is saying is there are physicians, and this only attaches to procedures. Part of the compromise agreement was to take out pharmaceuticals. So this is a gold carding or an exempt status that a physician can achieve. It is specific to procedures. And so think about something that's really easy would be like orthopedics, right? So you have orthopedic surgeons who specialize in, let's say, elbows. And so if that particular orthopedic surgeon does, I don't know, 25 elbows, right? As soon as they've done, and this whole process and the paperwork and the requesting the permission of an insurance company to move forward with, it's a acknowledgement of an insurance company to a provider saying, look, you're really good at these. You don't ask for us to pay for this elbow treatment when it's not appropriate or when it's not medically indicated. And so an acknowledgement of you just being a really good doctor and you're doing the right things, and we're just going to ease this burden. For the next 12 months, you don't have to ask us to do that elbow procedure. Does that help?
Mr. Bully, you have something to add to that?
And just in addition to that, remember our conversation in Saratoga where we met with the new hospital administrator and he talked about the man hours that are required to do these prior authorizations. This expedites that process. So if we have good actors, which is what we hope we have, this eliminates the need for them to spend all those hours going through this process. And so to a certain degree, your analogy or your example was a good one, and also realize we have a lot of providers in our state with a lot of insurance companies. And each one of those, we have to meet these criteria to get the gold carding standard. So that's one of the reasons that Ms. Bush talked about, that we've lowered it to 5 instead of 10. There just isn't enough economies of scale. There's not enough volume to get to 10 in some circumstances. So we're trying to split the baby here.
Okay. I hate that term, but go ahead, Ms. Bush.
Biblical.
Proceed.
Mr. Chairman, members of the committee, there are some other provisions in that gold carding exempts area that were compromises back and forth for insurance to be able to look at the full 12 months. There's language in the bill that originally was for a 3-month look back. We've addressed that to make it so that it's cleaner, it's very transparent. Everybody has all the tools that they need to make sure that the good actors are rewarded and the bad actors are addressed. And so with that, I'll just move, there's some effective date changes that were proposed. And so because of the gold carding section and wanting to make sure that all of the technology is in place and that the insurance companies have the time to really implement this well, we have moved or adjusted that effective date for just the gold carding section to the 1st of January of 2026. The rest of the bill is effective this summer, July 1, 2024. With that, I'll stand for questions.
Okay, before we ask any questions, does anybody else in the group want to add to that? Just real briefly, and then we'll ask you all questions.
Mr. Chairman, briefly, Mike Mosier, Cigna, and also speaking on behalf of the Pharmaceutical Care Management Association, the PBMs, which was part of this discussion. First of all, having been through this process for a while, this was a great experience, lots of trials and tribulations, but we'll remember the fun parts more than anything else. One thing I do want to point out is that we also collectively support the Board of Medicine amendment that Mr. Bodenblust kicked out. So we're in support of the bill, we are in support of the amendment, and we're singing Kumbaya, sir.
Don't sing. Anybody else have a comment, quick?
Mr. Chairman, I just wanted to touch on a couple of other points to make sure that you're still aware that these important points are still in the bill. There's still reporting requirements that'll be promulgated through rule with the Department of Insurance. There's still an online portal required for applications or for prior authorizations. And then one of the changes that we did make, it's on page 11 of the engrossed copy, having to do with consultation after issuing an adverse determination. Instead of having that peer-to-peer contact take place during that initial 5 days or 3 days, they have 5 days afterwards. And we actually think this makes it more doable. When you consider the timelines that physicians and other providers work on, having them be able to get a hold and consult and talk with the insurance companies, the decision makers at the insurance companies, we didn't think that that might be able to be done in that short time period. So we've given a little extra leeway on the back end before the determination is upheld or determined.
Okay, thank you, and that's pretty important. I know that in my own personal experience, when I have to do a peer-to-peer, it's very difficult. I get called by the other physician on the line, and I'm busy with patients. It's very tough to coordinate, so 5 days is reasonable. Okay, anybody else before we ask you questions? Heather?
Mr. Chairman, thank you. Heather Roday from Blue Cross Blue Shield of Wyoming. Just wanted to echo our support for this bill and the amendment having been folded into the engrossed copy is the result of many hours. Wanted to thank all of the providers for the compromises that were obtained. There were lots of them, and we appreciate all of the frank and candid conversations that we've had to get to where we are. So thank you, sir.
And I re-acknowledge Senator Dockstader and Representative Penn did a lot towards this. They're experts now. They're thinking about going to medical school. No. Okay, committee, are there any questions at this point? Senator Barlow.
Thank you, Mr. Chairman. So one of the things I see is added between the copy that came to the House and the gross copy is the National Physician Identifier. At least I can't readily find it. So if it's there, it's not in the same place as it is now. So would it be the testimony that all, I guess my concern is we changed it to healthcare provider and then we're talking about a national physician identifier. And so I just want to make sure there's a continuity between healthcare provider and physician identifier, and whether a nurse practitioner who is not a physician is actually in that system, or some other person who may be doing a procedure through their licensure. So anyway, that's my first question. The second question related to that is, it talks about after completing, granted a 12-month, they're granted something. This is page 20, lines 4 through 10. Granted, they are granted this 12-month exemption. And then on the next page, 21, lines 11 through 13, they're not required to request an exemption. So how can you be granted something that you don't request? There's an automatic system in this identifier. If it is, that an explanation of that would be helpful. Thank you, Mr. Chairman.
Okay, you got two questions before you go ahead.
Mr. Chairman, Senator Barlow, I'll do my best. So as far as the National Provider Data Bank, I don't think that that includes anyone outside of physicians, and I could be wrong, but I think that that is specific to physicians. Is that true?
Mr. Bowler, go ahead. Go ahead.
I'm wrong.
Mr. Chairman, Senator Barlow, I'm pretty sure both PAs and nurse practitioners have NPI
Yeah.
numbers.
And he is correct. Yeah, in order to.
It's a good question, though. Yeah.
As to the other question, which I think I'll do better, I don't know. We did feel like it was important that it was automatic. So the lines 11 through 13 on page 21 in subsection C are a really critical component of that bill for medicine, in that it's an automatic process that happens on the insurance side because they're the ones who have all of that data. They have all of the claims. It's not something that the onus lives on the physician to have to ask for this for every procedure. And so that is a component of the bill that's important, and it does speak to the extended effective date in order to put all of that technology in place and create those mechanisms by which some of this can be automated.
Follow up? Go ahead, Senator Barlow.
Thank you, I appreciate that, and the second, I guess, is a follow-up to that is on the qualifications to receive this, which I guess now is on the payers to come up with this process and automatically qualify people. Romanet 2, which is the bottom of page 20, talks about this goes to the number of requests. Do those have to be successful requests or just requests? Thank you, Mr. Chairman.
Mr. Chairman, Senator Barlow, that's where the percentages come in. So, yeah, so it's that 4 of the 5 have to be approved. And I think what else is important, and insurance was helpful, is that if any of those denied, or if they were originally denied and then overturned in appeal, those requests that were acknowledged or approved at some point, even in the appeal process, do also count toward that provider's 5.
Here's an unrelated question, but I'll just throw it out there because it's related. That 4 out of 5, when does that reset? Yeah, I mean, if you go through 5, then does it reset and you check the next 5, or do we go on average over 20, or how would you establish that?
Thank you, Mr. Chairman, and I think that's part of that 90% is 12-month period. Is it a calendar 12 months? Is it a rolling 12 months? Just clarify it to us, is it, where do we 12 months? Because if it's a rolling 12 months, which I think this could be interpreted as, then it changes all the time. Every prior authorization changes the formula. If there's a denial, all of a sudden now you're at 3 out of 5. I throw it out there for consideration. This is a formula-based system. You got to have you got to at least identify the time frame. It seems to me. Thank you.
Mr. Chairman, Senator Barlow, I'm going to look for it, but there is language in the bill that is very specific to how long the provider is granted that exemption, and it is 12 months. And now I'm not sure if any of you are finding the page. Yeah, I think so. So look to page 20. What's it?
I feel an answer coming down the table there.
Yeah. Anyway, I think I'll just start with mine, and it looks like there's some other thoughts. But on page 20 at the top, it says provider exemptions from prior authorization. It does very clearly state that the provider is granted a full 1-year exemption from completing the prior authorization process. And so I would interpret that to mean that is the 12 months. Once they have hit the threshold and they're granted that exemption is, good and will be acknowledged for the full 12 months after that. If there's different interpretation of that here, I'd be welcome. It's good enough. It's good enough.
And just to clarify, one earlier question, because I just had to look it up because I remember, the MPI actually is National Provider Index. It's not a national physician, it's national provider. And all providers, nurse practitioners across the board, we all have to have that number. It's a 10-digit number that took me 3 years to memorize mine, so. Senator Hutchins.
Just a kind of side question here. I'm looking at the 12-month period for the procedures, and I'm just wondering why you came up with 12. The clinic I went to for my total knee and total hip, my doctor did 8 knees in a day, 8 hips in a day, and I just don't know how he did it, but he did it, and to me, very successfully. So how did you choose 12 months when he's just going all day long?
Go ahead, Ms. Bush.
Mr. Chairman, Senator Hutchings, I would say we didn't pick that. That was the model language from the American Medical Association. It's been the time period that's been used in the 5 states that have done this, and so I wouldn't give us too much credit. I would just say that it was the language that we were given, and there wasn't disagreement.
Mr. Boley?
Mr. Chairman, Senator Hutchins, and that's a great example. Knees really don't need prior authorizations anymore because a lot of those are done so frequently and so quick. But we're talking about other procedures where there are limited numbers. And so getting to 5 is difficult, let alone 8 in a day.
Okay. Further questions, committee? Senator Bouchard.
Yeah, Mr. Chairman, going back to what you were saying, because I have seen that NPI called National Provider Identifier. But this, I mean, I see this worded differently. I don't know if that's just for their internal system, but there are other providers that could fall into this, and not just physicians. So I'm wondering, does this need to be clarified?
Where are you
somewhere?
looking at?
On page 20, line 6. Does that NPI have to be put there differently to make sure we're all on the same page? Instead of this new NPI name, this one says National Physician Identifier, where it should be National Provider Identifier.
And I think I would agree when we get to that, but does anybody have a comment? And I think National Provider Identifier would be more appropriate.
Mr. Chairman, I believe we'd be in agreement. As we crafted the language, we were trying to help the insurance companies as well as ourselves understand how we would capture the data to create the gold carding. So I think the definition of NPI definitely fits in this situation. And it doesn't actually say NPI. So there may be other identifying numbers available for providers that don't have an NPI number. So it doesn't actually say, it's just a unique number, one way to identify those providers. But NPI would, the definition for NPI would be fine too.
Follow up, go ahead.
So just to clarify then, is this not related to the NPI? This is just your internal system identifier? No? So, okay, so anyway, that's why I'm trying to figure out where we're at.
And I would ask a question, would it be adverse to change that physician on line 6 to provider rather than physician? Okay. Okay. Further questions, committee? Go ahead, Senator Dockstader.
Ms. Bush, we gave you the engrossed copy. All of your notes are on the original copy. Is that correct? Would you be willing to share your original copy, and I'll get somebody to do a transition of those?
When he presents the bill on the floor, is what he's
I
asking.
sense this coming, and so that's why. That's why I could.
Mr. Chairman, Senator Dockstader, I'll be happy to work with you, and I'll create a document that walks through these very clearly and with the page numbers that accompany the engrossed copy.
Thank you, appreciate that.
And his desk mate may be willing to help him, perhaps. May. It's not a shall, it's a may. So, okay, further questions for these folks? See no questions? Oh, go ahead, Senator Barlow.
So I just asked the group to think through that 1 year thing a little bit more. And the reason I say that is because if you go to page 21, line D, and this is someone that does not receive an exemption, they get an opportunity once every calendar year. So it's specific in this, and it seems a little ambiguous in how that year rolls otherwise. Maybe it's fine, but I just want to make sure that there's cross-pollination between the two issues, the same issue in two different places. Thank you.
Mr. Chairman, Senator Barlow, thank you. I appreciate that. We will work together to make sure that the language matches what we think we're doing.
Okay, comments, questions? Go ahead, Mr. Burke. Mr. Bowley, I can't talk.
Chairman Baldwin, committee members, just in closing, we've also want to just express our support for what Mr. Bonham-Bless will bring from the Board of Medicine. He brought an issue forward to us in Saratoga, and in all of the melee and all the meetings, it kind of got missed, but we think it's a really important addition, and we've all met together and we're all in agreement, so.
Now that you bring that up, let's just walk that in real quick so the committee knows what that is. The committee, you should all have a copy of that. Welcome back. You can talk more this time.
Thank you, Mr. Chairman. Kevin Bonham, blessed Executive Director of the Board of Medicine. And first, I was at the meeting in Saratoga, and I thought this bill was DOA. So my hat's off to Senator Dockstader and Representative Penn and this group, because I guess we're in the Lenten season. Maybe it's resurrection occurred in this or something, but my hat's off to everybody. So, and really, it's an insurance bill, but there's just one item in here that did cause some concern. And on what I provided to you, I gave you the existing portion of the existing Wyoming Medical Practice Act, where at some point in the past, and it's probably more than 20 years ago, the legislature decided to say that practicing medicine included rendering a determination of medical necessity. Now, I can see a couple of reasons for that. One may have been at some point, there were people with even less medical training than I have. Mine's a first aid merit badge, that's all I've got. But making these determinations and sending them back, and you didn't have a true medical review of it. The other is that it is possible, we talked about the bad actors, that a bad actor could be working for a company, be incentivized to deny as many as possible, and would not be, basically honoring their license and their training and everything else, and would be selling that out. So I think that was probably the origin of this. So what we suggested was, on page 10, the main is on line 18, after District of Columbia, you're striking the semicolon and then inserting or as otherwise required under Wyoming law. We think that would preserve the language that the legislature previously created in the Medical Practice Act. If the legislature wants to come back at some other point and either expand that or remove that, that's the legislature's ability, but we're not doing that then in this bill. So that would be the reason for doing it. And I want to emphasize this only applies to the adverse determination, which I started using the word initial, and I was told that's really not the right word to use, but it's the first time there's a medical reason given for denying prior authorization. It doesn't apply to the appeal because that's at a different level. There's national organizations. Commissioner Rood and his department actually approved those organizations. So we didn't want to get into that, but we wanted to make sure that first line, at least for physicians and PAs, we're still responsible, that if they did something nefarious, we would be able to reach out and touch them. So other than that, it's a fantastic bill. I'm truly amazed it's gotten this far, and you all did fantastic work. I would answer questions on that. One quick thing, if I could, as a government hack, I think, Senator Barlow, your question or concern about what is a year and when is it, I would certainly, in my stead, I would say I would do that in rule. We'd figure that out in rule and make it clear, because I think you're going to have an answer. But I think there's adequate rulemaking authority here to at least say it's going to match that or whatever it is. So I think that it can be addressed adequately along with a lot of the other procedural things. But I'm being careful not to mess in somebody else's bill or somebody else's department. So with that, any questions? But otherwise, I appreciate your consideration of this.
Senator Barlow.
Thank you, Mr. Chairman. Thank you, Mr. Von Blessed. The other part was the striking the medical, and that seems to be acceptable across the board. I think they're all medical professions, but is it damaging to have it, or is it just unnecessary? Thank you, Mr. Chairman.
And Mr. Chairman, Senator Barlow, I apologize for not touching on that. My suggestion was to pull that medical out because it was written when it was for physicians, and physicians practice medicine. Within the licensing world, nurses practice nursing, podiatrists practice podiatry, et cetera. And so it was kind of clouding things to say medical. So I suggested you pull that out. Just makes it a little simpler.
Okay, further questions? Senator Dockstader.
Thank you, Mr. Chairman. Just a request, if I could, please. This is maybe more specific to Mr. Foley and Ms. Bush, but all of you. If you get a moment, would you drop me an email with how many actually people or organizations you represent? Because I sense that we're all together on this finally. I had to snap a photo of this moment of unity. So if you could do that, I'd like to work that into the conversation and say, this is how many people you represent as we all come to the table with this agreement. Thank you, I'd appreciate that.
Okay, that photo will be published somewhere. Yeah. Yeah. Okay. Just an advice to those online and those in the room who wish to testify on this. We're going to bump up against time. We're only going to get one bill done. But I do want to finish this one bill before we go up to the floor. So with that in mind, if we've got some comments, if we can keep them a little short, they don't. Yeah, let's, Department of Insurance. Welcome, introduce yourself.
Good morning, Mr. Chairman, committee. My name is Chris McCann with the Wyoming Business Alliance. I just wanted to lend the support from our group to this piece of legislation. We're very appreciative of the collaboration between all the folks that you had testified before you. And from a business perspective, we just are excited that people are going to be able to get the care they need in a timely fashion and then be able to get back to work and get on with their lives. So we're in support of this bill. And Senator Dockstader, I'd be happy to add our name to that list of folks. So thank you. If I stand for any questions.
Commissioner.
Mr. Chairman, Jeff Ruth, Commissioner of Insurance. I just want to be here for questions. We're neutral on the bill. We've been monitoring it. We understand there's going to be a little bit of heavy lift on our part on some of this. What I've been trying to tell folks is to temper expectations in some way, because we only actually oversee about 17% of the health insurance market. Large group plans, TRICARE, Medicaid, Medicare, we won't be able to enforce against any of those entities. And so this will not be all encompassing as some might think. And we're going to have figure out a way to do some data analysis on gold carding and do some data analysis on some other things here. But we'll get to it.
My question to you, Commissioner, is it doable within the enactment dates that you see on the bill?
Mr. Chairman, we'll get it done, one way or the other. I mean, we can start enforcing a statute without rule by the common meaning of what is in statute. And we can start giving direction even before a rule comes out, just so people are prepared and understand where we're going.
Great. Questions for either of these two? Senator Barlow.
Thank you, Mr. Chairman. So this is actually a really unique effective date thing, because there's actually 3 effective dates in this. And the gold carding, now that I look at it and try to understand how this is created, the gold carding is actually not effective until 2026. So the timeline issue that I was visiting with and concerned about, we actually have a legislative session between now and then if it needs to be sorted out. So I just throw that out there for the body, et cetera, that anyway, there is more time on that gold carding if that date or that timeline issue becomes concerning or whatever. Thank you, Mr. Chairman.
Mr. Chairman, that's a really good point. Actually, something that's not in here, which I think is going to be actually a large lift for us, is we're going to get a lot of complaints from the medical profession, and they won't know the status of the plan. They won't know if it's an individual or a small group or a large group. They just know it's a plan. And we're going to have to sift through that, because there's literally over 750 different entities that are licensed to sell a healthcare plan in Wyoming. And that's one of the first things we'll just have to work through.
Education. Very good. Okay. No further questions for these gentlemen? Anyone else in the room? Jump up. We're short on time. For more than one, come on up to the chairs, please. Welcome. We haven't seen you yet this year.
Thank you, Mr. Chairman. Thank you for the welcome. And I will be brief. I really can't add much to what they said.
Identify. Tell us who you are.
I'm Marguerite Herman, and I'm here today as a consumer representative for the NAIC, the National Association of Insurance Commissioners. And this has been a topic for all the consumers, and they were very interested to watch this as the very last state to actually regulate this area of health insurance. And I will just say that I sort of watched this elaborate compromise process from the sidelines, and I just can't admire these people enough, because they both came, and the ultimate winner in this, I can tell you, is the consumer. And that's been my position from the beginning. I have a deep interest in the health of the health insurance industry in the state, but also the providers, and creating an efficient method of pre-authorization, and this bill and the compromises they made seem to achieve that. And I just want to point out a couple of things that I've been advocating since the beginning, is that in all the communications, the dealings and negotiations between provider and the review of the insurance company, that the enrollee is involved in that, not as necessarily one of the negotiators, but always aware and noticed. And because they're the ones with the contractual relationship, they're the one paying the premium, they're the ones that are due the coverage by the insurance plan, whatever they purchased. So they should be at the center, and this bill does that. It includes them in all the communications and notices, collects data to see if what we're doing is working, and it streamlines the process. And that's what we wanted to do, was to get rid of unnecessary delay, complications, denials, appeals, and that sort of thing. And I think this achieves that. So kudos to everybody involved, committee members and interested parties. And again, at the consumer, we're sort of sitting in the middle of the process, and we think it's a great achievement. So thank you.
Thank you. Any questions for Ms. Garman? Seeing none, thank you very much. Anyone else in the room? We've got a couple of folks online. They want to testify, I'm assuming.
Mr. Chairman, we have Bruce Spencer online who'd like to testify. I'll admit him.
Okay, those online, Mr. Spencer, and you say Ms. Folland is here as well?
I believe Ms. Folland wanted to testify on another bill.
Okay. Mr. Spencer, good to see your face again. If you could speak to us briefly.
Good
we're
morning.
About to run out of time. Go ahead and introduce yourself and talk to us.
Good morning, Mr. Chairman, members of the committee. Bruce Spencer, representing the Mountain Health Co-op, and it's over 18,000 individual insureds in Wyoming. I know someone wanted to know numbers, so I thought I'd throw that out there. Greatly appreciate all the assistance and hard, sometimes painful work of everybody involved in this bill, but we strongly support the bill as amended before you. And we also appreciate the physician regulator in working with us on an amendment, and that is a good common sense amendment. We support that as well. We support the bill. Thank you.
Thank you. Any questions for Mr. Spencer? Seeing none. Thank you very much for visiting with us today. Anyone else? Donna?
So, Mr. Chairman, Ms. Folland did raise her hand, but she declined the invitation to be admitted,
Okay.
so.
She's here in spirit. Okay, we'll close public comment. Committee, what's your pleasure? Moved by Senator Dockstader, second by Senator Hutchins. Committee, discussion, amendments, comments. Go ahead, Senator Barlow.
Thank you, Mr. Chairman. So I don't think, I'm not going to make any amendments, but I have a challenge with legislative findings in any bill. That's just me personally. And then I think the physician identifier, that issue, those are committee of the whole things. People can bring them, but for the time being, I think we pass this out as is. We go to the floor and we can bring up those other issues. That's just my suggestion based on the time we have. Thank you, Mr. Chairman.
Senator Bouchard.
Well, Mr. Chairman, I mean, it seems like every time that I've tried to put legislative findings in a bill, everybody said, no, we can't do it. And this bill has it. I'm a little concerned where the patient-provider relationship thing and third party, there's advocates that come in for patients, and this blocks them out. I mean, I think it's a simple amendment. We can just do it right there and just take that part out.
Yeah, I would agree. Would the committee be adverse to a committee of the whole amendment, or would you rather do it here?
Sir, I'd like to do it here.
Let's go ahead and do it here. Senator Hutchins, make a proposal, please.
Thank you, Mr. Chairman. I move that we amend page 2, lines 5 through 12, or no, 15.
Yeah.
Thoroughly delete that out of the bill, or even though I seconded the movement, I cannot vote for this bill or advocate for it unless that finding is removed. Thank you, Mr. Chair.
Is that reasonable? I think. Did you get that, Donna? I think we
you.
got 3 seconds.
There you go.
Okay. You've all heard that amendment. All in favor, say aye.
Aye.
Those opposed? That amendment passes. Further amendments? Oh, yeah. What page? On page 20? I'm just going to read off yours since you got it open. Page 20, line 6. Deleting physician and deleting identifier. Changing that to National Provider Index. Is that, somebody shake their head, does that sound reasonable, or you what? Mr. Blondebust? Just leave identifier, but change it to provider rather. So it would read National Provider Identifier. Okay? You all heard that?
Aye.
All in favor, say aye.
Aye.
All opposed? That amendment passes. You got that one, Donna. Okay? Further amendments? Well, we need to get this amendment in.
Yeah.
The amendment proposed by,
Mr. Chairman, so I'd move the amendment provided by the,
okay, we're gonna move in a second. Everybody's got that? You got a copy? Very good. Any questions? No. All in favor of that amendment, say aye.
Aye.
Opposed, say no. Further amendments, changes? Question on the bill. Let's take roll.
This is a roll call vote on House Bill 14 engrossed as amended. Senator Barlow?
Aye.
Senator Bouchard?
Aye.
Senator Dockstader?
Aye.
Senator Hutchins?
Aye.
Chairman Baldwin?
Aye.
We have 5 aye, Mr. Chairman.
That bill has passed this committee. We'll be hearing it on the floor. we will move the other bill here, we'll move it up to Monday. So we'll be doing 4 bills on Monday. We start at 7:30 Monday morning.
Slave drive.
But they're short ones, right? Okay. Thank you very much, committee. Thank you, everyone who testified. Please don't sing Kumbaya.
Kumbaya, my lord, kumbaya.